Associate Professor of Nursing and Public Health at Regis College in the Richard and Sheila Young School of Nursing, and the coordinator of Community Health Nursing and Regis College Global Nursing. So on behalf of Regis College, I'm pleased and privileged to welcome Dr. Oni Blackstock as our featured guest today. For any of our listeners who may be unfamiliar, Dr. Blackstock, founder and executive director of Health Justice, is recognized as a thought leader and influencer in the areas of HIV and health equity. She is a primary care and HIV physician and intersectional equity advocate with expertise in racial, gender, and LGBTQ equity. She previously served as assistant professor in the Division of General Internal Medicine at Montefiore Medical Center, Albert Einstein College of Medicine in the Bronx, New York, and as assistant commissioner of the New York City Health Department, where she led the city's response to the HIV epidemic. Within the healthcare and public health arenas, Dr. Blackstock has developed and implemented racial equity programs and initiatives, including the first bureau-based racial equity and social justice initiatives program at the New York City Health Department, which have led to improved workforce equity and more equitable administrative and programmatic policies. Additionally, her own experience living at the intersection of several marginalized identities has informed her deep commitment to advancing health equity. Dr. Blackstock holds degrees from Harvard College, Harvard Medical School, and Yale School of Medicine. She has been the recipient of numerous awards and recognitions, including media outlets such as Go Magazine, Out 100, and Essence Magazine, and community-based organizations such as the Callan Lord Community Health Center and Exponents. So welcome, Dr. Blackstock. Thank you. While I indulge your summary, as a regular admirer, so as mentioned before, as a regular admirer and follower of your work and that of your twin sister, Dr. Uche Blackstock, I am sincerely honored to host you this afternoon.
Thanks so much for having me, Dr. Fardy. Look forward to our conversation.
Thank you. I still remember very vividly when you were kind enough to follow me back on Twitter. So thank you.
I try to, like, if people have like the bio, there's enough information. It's not like, an avatar or something like that. I usually try to like follow people back because it's a bi-directional learning.
Yes. No, it's been fantastic, especially in this past year. So thank you. So my first question, if you don't mind, would you highlight a bit of your professional journey into exploring and examining social determinants of health and health equity?
Okay, sorry. I'm so sorry. Can you say that one more time?
Sure. Would you highlight a bit of your professional journey into exploring and addressing social determinants of health and health equity?
Oh, sure. Yeah, so a lot of times when I think about my career path, it really starts from my family, my roots. So my mother, Dr. Dale Blackstock, passed away in 1997, but she was a physician herself. She was a nephrologist and geriatrician. And so my sister and I really grew up at the hospital with her, where she worked in central Brooklyn at Kings County Hospital and downstate State University of New York Medical Center. And so we spent a lot of time with our mom at work, looking at, observing her, shadowing her, and also just seeing all of the joy that she derived from the work that she did. And so even though she was a nephrologist, which we tend to think of as, sort of being really in the hospital, she did a lot of community outreach and community health related education. So often having like health fairs and educating people about high blood pressure, kidney disease. And so was able to see the ways in which sort of advocacy and service were very much intertwined with medicine, and really thinking about, our role as healthcare professionals in addressing social determinants of health. And so just seeing my mother, that really inspired myself as well as my sister to go into medicine. But I think seeing the work that she did, the community health work, also highlighted the ways in which health is not just dictated by, the healthcare that someone receives within a clinic or a hospital, but also so much about their social context, the housing, their access to food, employment, the built environment, how all of that impacts health. And so just to say, I was drawn to HIV medicine, so I'm a primary care and HIV doc. And HIV, I think, is like the perfect lens to really see the ways in which both structural, we call them structural determinants of health and social determinants of health, so impact people's ability to protect themselves, for instance, from HIV, and if they have HIV, be able to, engage in care, go to their appointments, take their medicine. All of that is impacted by these larger social determinants of health.
Thank you. I'm going to have so much fun this afternoon, I know. Thank you. I'm so excited to have you here. I teach community health nursing, so everything you just mentioned, it resonates so fully with me and with my students, so thank you.
Awesome.
My second question, I apologize. My second question, in a Mother Jones article of last year, specifically April 10th, entitled "These Twin Sisters Are on the Front Lines Fighting in the Pandemic of Inequality in New York City," you and your sister, Dr. Uche Blackstock, cited your mother, Dr. Dale Evans Blackstock, as a pivotal role model, your sister even stating, quote, "We wanted to be just like her." Would you speak a bit more to your mother's influence? You mentioned her previously, but perhaps even a bit more.
Sure. Yeah. So, our mom, had a very different upbringing than my sister and I. So, my mother was raised by a single mother, along with her. My mom had 5 other siblings. She was raised on public assistance. She often talked about how she would have to put cardboard in the bottom of her shoes because they were so worn, and talked about like waiting online for the government cheese, just different stories she would relay, some of which were humiliating and embarrassing for her and for her siblings. But, my mom, was very self-disciplined and ended up going to Brooklyn College, which is one of the city universities here in New York City, and had a mentor who encouraged her, as well as other Black students who were in her class, to consider medical school, to apply to medical school. And it's funny because I think she had thought about being a physician, but it wasn't something that seemed real to her. She had, I think, thought about being a teacher, and then one of her teachers in Catholic school told her that, she would never be able to amount to much. So, she had didn't have a lot of sort of positive messaging when she was growing up, but then had this one mentor in college who really encouraged her to apply to medical school, which she did. And so my mom went from Brooklyn College to Harvard Medical School, where she would always say it was culture shock. She felt like a fish out of water. So many of her classmates, their parents were professors at Harvard Medical School. And I actually, when I actually have her class picture, and when I look at it, I see, the names of folks like Peter Gans, who created one of the Swan-Ganz catheter. And so, it was a real big adjustment for her. So after Harvard Medical School, she came back to New York City and did her training in Harlem Hospital, which is a special place for me because she trained there. It's also where I did my HIV medicine fellowship and where I see patients in the HIV clinic. So it's wonderful to have that connection to her. But just to say, I think, as I was saying before, like for my mother and my father as well, both had a very strong sense of community advocacy and activism. And so as we were growing up, they would often take us to anti-apartheid marches, to anti-racism marches. And so, and then also my mother was able to apply, sort of her interest in equity and justice to her work. And so I think being able to see that gave us like a sense of possibility of, being a physician, it's about that one-on-one encounter with your patient, but it's also about like so much more and not limited to, the walls of a clinic room or office. So my mom, so just seeing her practicing in Brooklyn and just seeing all of the collaboration she had with community partners was really inspiring and really motivated us to pursue medicine.
That's beautiful. Thank you. Before we focus a bit more specifically on our pandemic, would you explore a bit of the underlying health disparities that predate COVID?
Oh, sure. Yes. So, just when we think about health inequities, I think, as you're suggesting, like the pandemic has sort of amplified this focus on health inequities, particularly related to COVID-19. but I have myself, and I have many colleagues and people and predecessors who've been studying health inequities for a very long time. These are very deeply rooted. I'm most familiar with the experiences of Black people in the healthcare system. We know that there's similar experiences that Latino and Indigenous people have also had, but I'm able to speak more to the experiences that Black people have had. And just really starting back from the beginning of the slave trade, the role in which physicians and other healthcare professionals have played have sort of been in contrast to like what we think of in terms of like what a healthcare provider should be doing in terms of maintaining someone's well-being. It was often physicians were often used to establish the soundness of people who were being sold or sold for slavery, sold into slavery. And so just to understand that the type of care then that people received, particularly during slavery, was, very poor quality care, because it really wasn't about keeping people healthy and maintaining their well-being. It was about this individual being property, really. And so, there's lots of, there's, I think I was mentioned, Medical Apartheid by Harriet Washington is a really important book that I would recommend everyone actually in healthcare read. But she talks about the ways in which people who were enslaved often took care of one another in terms of using different remedies and medicines that were passed down over the generations, and that if those didn't work, often slave owners were then, responsible for the care of the enslaved person, and would sometimes have to call a physician to help them with the care of the enslaved person. But the issue is that they often didn't want to have to pay for a doctor to like take care of folks. So just to say that the care that people received was very minimal, very poor quality. And that there also are no hospitals that Black people could really go to during slavery because of segregation that existed. And that continued on even after slavery was abolished, where Black people were really limited in terms of the hospitals and the care that they could receive. There was a whole like Black hospital movement that happened. So these were the hospitals that Black people were able to go to. But these, they were all over the United States, but it was some were very hard to access, and they were also poorly resourced. So we just have sort of generations of Black people not receiving the proper care that they need within the healthcare context. And then we know also that, once there was desegregation of hospitals, which was pushed by Medicare, actually, in order to get Medicare dollars, hospitals had to desegregate. And so, as we see more hospitals becoming integrated, we would think, okay, that's great. That allowed, Black people more access to quality healthcare. But then we also know that there's provider bias. And so there's a whole literature on how the interactions that Black patients have with their healthcare providers, how that's very different from the interactions that, say, a white patient might have with their healthcare provider. We know that when we look at markers of like verbal dominance, for instance, providers of Black patients tend to like overtalk Black patients. They tend to use a less patient-centered approach. They tend to be there's like less sort of shared decision-making being done. And so all of these things, so like, the lack of sort of access to care, which still continues now, as well as sort of the sort of interpersonal interaction, the provider bias and provider racism, that also impacts the quality of care that people receive. And then that's just within healthcare. And then we think about all the other social determinants of health. So we think about like housing, and we think about policies like redlining, which no longer exists, but really restricted the areas in which Black people could live, thus concentrating poverty, and also concentrating poverty in areas that have like poor air quality, that are next to factories, things of that nature. So I know I've just said, sorry, this is like tons of information, but all of these things really have worked in concert over the years in all of these different domains to affect the health of Black communities, as well as Latino, Indigenous, and other marginalized communities.
And then again, speaking as you did before to the very real, I think oftentimes social determinants of health is rightfully addressed or referenced, but social and structural to the extent that we're seeing now. I think oftentimes
Yes.
social, almost in the absence of structural, not necessarily recognizing the two are working in tandem, not to the benefit
Yes.
of the individual.
Totally. And I know you may be familiar with Jonathan Metzl and Helena Hansen. They have a structural competency like that, right? So just really highlighting, like, I think there has been this focus, as you were saying, on social determinants of health, but really what are the structures, what are the policies that are driving the social inequities that we see, or health inequities that we see. So when we think about even mass incarceration, or not having health care for all of these are policies that then can impact health inequities and social inequities, and then impact people's health.
Thank you. On November 23rd of 2019, Out Magazine named you among its 100 honorees for your notable work in launching the Made Equal initiative in New York City. Would you describe a bit more of the initiative and its intended aim and impact?
Oh, sure. So, within HIV, there is a great deal of work done on stigma. And so, because we know that people living with HIV often deal with internalized stigma, so feeling a lot of shame for the diagnosis that they have. And then there's also stigma that's enacted on people living with HIV too. For instance, someone may not want to have someone living with HIV as their sexual partner, or may not want to sit next to someone with HIV, or may not want to share a spoon because of the information that they have. And so the campaign was intended as an anti-stigma campaign to really educate the public on the fact that when people are living with HIV and they're taking their medications and they achieve something called viral suppression, which is when the viral load is suppressed to undetectable levels, that they are not at risk for passing HIV onto their sexual partner, because for so long people living with HIV have been made to feel like disease vectors. And so it's sort of this favorable side effect of HIV treatment, that not only does the treatment help the individual who's living with HIV, stay healthy, but it also effectively erases their risk of passing HIV to a sex partner. And so we wanted to make sure that people living with HIV knew about this message, and also that the general public knew about this message as well. So that was our Made Equal campaign.
Thank you. In your former role as Assistant Commissioner for the New York City Health Department, in which you led the city's response to the HIV epidemic, you noted some parallels between governmental response to HIV and COVID. Would you explain that a bit more fully?
Oh, sure. Yeah, so I think, there are a number of parallels that we see when we think about the early days of the AIDS epidemic here in the United States and the COVID-19 pandemic. And I think probably what's most striking in terms of similarities are the lack of a sort of competent response by the government, and also the delayed and inadequate response by the government to sort of addressing the AIDS epidemic, as well as the COVID-19 pandemic. So when we think about the early AIDS epidemic, for instance, it took Ronald Reagan, I think, about 4 years to actually say the name to say AIDS after it was first identified. There was, a lot of sort of avoidance of addressing this issue, this infection that was killing many, many people. And there was a lot of, concern that this inaction was related to the fact that it was gay folks and people of color who were being impacted most by the epidemic, and that's why they were slow to act. And sort of similarly with COVID-19, again, seeing this very delayed, inadequate governmental response, seeing certain communities disproportionately impacted as compared to others. So those are some of the similarities, and I think also the approach that we take to like educating people has some parallels. So this idea of harm reduction, which sort of emerged during the AIDS epidemic with, how do we, without shaming people, give people the tools they need to protect themselves. And so I think there's also parallels, obviously, with wearing condoms and masking that people have drawn as well.
Yes, I caught your informational sheet that went viral about engaging in safe sexual activity during COVID-19.
Oh yeah, that was a lot of fun. We got we were hearing very early on in the pandemic. This was like in March of 2020, that a lot of community partners had questions about how to continue to have sexual activity, during a pandemic. And we understand, how sexual health is a really important part of overall health and well-being. And so we very quickly developed the guidance, which it was exciting to see it go viral. There was clearly an appetite for that information.
Yes. So rightful scrutiny, as I don't need to tell you, rightful scrutiny of the vaccine rollout persists across most states. What messaging and action do you believe need to occur to allow for a more informed and equitable rollout?
Yeah, my sister and I were actually writing an op-ed right now about this very topic. So I think a few things. Okay, so I'll just talk with, at least here in New York City, what we've seen. I think, obviously the rollout for most of the country has been very slow. It's been somewhat disorganized, not very streamlined. There's been a lot of confusion. Some of the positives, at least here in New York City, that we've seen, for instance, vaccine sites are very community-based. And where I live here in Harlem, we have like 9 vaccine sites, which is great. But I think what's really important is for the folks who are doing the rollout to understand is that just having vaccine sites located in highly impacted neighborhoods is insufficient, because if you're still dealing with lack of access to internet to be able to sign up, lack of digital literacy to be able to navigate a registration process. And then obviously we talk a lot about, medical mistrust, which is really a symptom of the discriminatory and racist experiences that people have had, and where people don't feel like the government, these healthcare institutions are trustworthy. So in order to, I think, counter some of these issues, we really need to see partnership with community-based organizations that do have the trust of community members, and faith-based organizations. So I think there's so much more could be done. Like we could provide, for instance, like funding to a church to buy a freezer, like to buy an ultra cold storage freezer, so that they can deliver the vaccine to their congregants, or the same thing at a mosque. And some of that is starting to happen. We're starting to see some like pop-up vaccine sites at churches and things of that nature. But there needs to be like a really a full-throated, like intense effort, really focused on these type of collaborations. And then also, we talk about mobile units. Like we really need to like bring this vaccine to where people are, and we need to be able to have trusted messengers, be able to answer any questions or concerns that folks in the communities that are impacted have. So I think that would be really important. I do also think the prioritization is problematic. The phased prioritization that was developed, because that we see within each priority group. So even when we look at healthcare workers and nursing home residents, we see Black and Latino people still being disproportionately impacted. So we see like Black and Latino healthcare workers, even within the healthcare worker group, still having worse outcomes than their white counterparts, and the same thing for nursing home residents as well. And so I'm concerned about, having sort of a race blind or color blind these policies, because they really ignore some of these like structural issues that really are driving risk. And so I think if we really don't get to like the real issues, then we're going to just continue to amplify and exacerbate the inequities that already exist.
I completely agree. As I don't need to tell you, but there's been increasing mention of vaccine hesitancy, and I don't discount that that is a very real concept. I just worry that oftentimes it becomes comfortably tabled simply as hesitation without regard for structural and social barriers that create and amplify that very hesitation.
Exactly. Yes, exactly. And I think the same thing a little bit with mistrust as well. Like, I think I keep on saying, like, how do we intervene on mistrust? How do we, and like, mistrust is just like a symptom, really, right? And it's just really about how do we, gain the trust of communities that have really been mistreated for so long. And obviously that can't be done, in a day, but we know that, for instance, like healthcare providers, like if someone has a healthcare provider, they often view that provider as really a trusted source of information. So, ensuring that providers are speaking to all of their patients and really encouraging them to get the vaccine, and, or having, I should say, shared decision-making conversations. If someone decides it's not for them, that's fine, but at least they have the information they need to make an informed decision.
I completely agree. And certainly not discounting the history behind hesitation, but not just simply comfortably tabling it for white folks to comfortably table it as history without regard for present day maltreatment. I think that's where the rub lies. That I don't discount the impact of Tuskegee, Henrietta Lacks, and the like, but I can't also discount what I'm seeing even in present day.
Totally. Totally, yeah. And so I think it's really important, like, for, not everyone has a healthcare provider or primary care provider, so that's like a whole nother issue. But I think if someone does, it's really important for that provider to, acknowledge and validate, any experiences that the person has had within healthcare setting or in the world that may be influencing their view of the vaccine or whatever other treatment.
Well, in the interest of time, I don't want to steal any more of your time, although I would
I can talk. I mean, I can talk for like 10, 15 more minutes if that would be helpful.
Oh, that's lovely of you. Thank you. As long as we're speaking about vaccine hesitancy, concern about rollout, ongoing maltreatment, to individuals, including our Regis College community and students within the community, who may be hesitant to receive COVID-19 vaccination for myriad issues or reasons, what would you say? I know that's perhaps a very loaded question, but I would welcome your perspective.
Yeah, no, I would acknowledge that it's very normal to have concerns about, something like a vaccine. I think, when there's like asymmetry in information, when people are not, don't have the information they need, it makes sense that they then will come up with different narratives about how and why things might work. But just to say that I would just affirm whatever concerns they had, and I would, just ask also ask and try to address what the concerns are. And then I would also just think about benefits and risks. So shared decision making, it's about providing the information, but also understanding like what the person's preferences and values are. And so I would want to understand there's some known risks, obviously, of the virus. Like, we know that obviously cause hospitalization and death. We know how to protect ourselves as well. And one other layer of protection is the vaccine. And there are unknowns about the vaccine, right? I mean, there's a known benefit. There's unknowns in terms of long-term safety. But I always just say, like, I know that I don't want to get COVID-19. Like, I want to protect myself. And it's possible that decades down the line that there could be some rare side effect that turns up. But right now, I want to do what I can to protect myself and also protect others. Like, that vaccination is not just about the individual well-being, but it's about us getting to a point where, there are high levels of protection in our community so that we can like stamp out this virus. So I think just weighing benefits and risks with the person and alternatives would be my approach. I think people assume because I'm a healthcare provider, I want everyone to get the vaccine. I do want everyone to get the vaccine, but I know that not everyone will feel like it's a good fit for them. So I think it's just making sure that we affirm concerns, that we answer whatever questions that folks have, and that we work with them to figure out, what's sort of the best decision, the most informed decision for them.
Thank you. Just one more question, please.
Oh, no, that's fine. No, I have a few minutes. Sorry, that was a lot. That was a lot. Yeah.
No, it's exactly what our community needs to hear. So I appreciate your perspective. I do. So given that our listeners come from myriad backgrounds, including our students who are pursuing different majors and programs, including healthcare, where could an individual or group make the greatest impact on structural and or social determinants of health and health equity, particularly amid our pandemic that's disproportionately affecting communities of color?
Oh, that's a great question. Yeah, so I think, for instance, some of the work that I've been involved in was with a professional organization that does advocacy work. So I'm part of this organization of healthcare workers here in New York City, where we, for instance, like reach out to elected officials, for instance, about the housing moratorium and about extending that. So I think what can be really helpful is for students and trainees to get connected with organizations that are doing advocacy and organizing that can then affect policies, because we know that it's like the policies that are really the structures that drive the social determinants of health and eventually these inequities that we see, and that the only way to really mitigate or reduce or eliminate these inequities is to get at these root issues. And so I think partnering again with a professional organization that is doing this type of work can be really, really helpful. And so I would definitely recommend that to students. And yeah, there are tons of groups like the Physicians for a National Health Plan. I mean, I'm talking about physician groups, sorry, but there are organizations that can be open to all healthcare workers, such as the one that I'm part of. But I think organizations like that allow you to feel like empowered, and then you're actually doing something. For instance, like we did testimony in front of the New York City Council about the rollout and what needs to be done from our perspective, needing more community-based sites or whatever it is. And then similarly, we also did testimony around the test and trace initiative and how to make that more equitable. So, what the great part is that healthcare providers, nurses, physicians, physician's assistants, people, often view us as trusted sources of information, and whether we deserve it or not, we tend to be highly respected. And so I would definitely encourage students to get out and have their voices heard as well. And they're really great student organizations that do this type of policy work as well.
Thank you. I think with just one parting question, not surprisingly, we've had increasing messaging, science communication, and the like within the last year, and we continue to do so. And I think with some benefit and with some risk. And if you had a magic wand to improve media coverage and science communication, what would you like to wave to see happen?
Oh, in terms of improving the science communication that's happening? Well, I think that, so I think one thing that's really important is, because I'm coming from the public health perspective, because I was at the New York City Health Department, and for instance, there's currently a big sort of mass campaign around getting the vaccination here in New York City. But, there aren't images of people in it. Or people who were trying to focus on, I think it was like a cartoon of the Statue of Liberty. And I think what's really important is for people to be able to, when communicating about something like a vaccine, is for people to be able to see people that look like them in a campaign, and then also to be able to convey the information in a way that is tailored to different audiences, right? So because different audiences may have different concerns. And so I think what would be really important is to work with community-based organizations that are located in the communities that are being impacted, because, a general campaign around the vaccine, it's meant to appeal to everyone, but it's going to leave a lot of questions. And so I think that community-based organizations like immigrant health groups, lots of different groups, a housing group, whatever it is, can tailor information so that it's relevant. And it resonates with the folks who they engage with. So I think just having, communicating in a way that is culturally responsive, linguistically responsive, that is at the level at which folks are able to understand this information is really important. Yeah, we haven't seen, like someone was asking me about celebrities, like having celebrities talk about the vaccine too. I think, I don't know if you know Tyler Perry,
Yes.
but I saw he was in an interview and he kind of went into his like Medea character and he was like, I'm getting the vaccine, like whatever. But I thought like, oh my God, that would be so amazing if that were a commercial, because so many people know Medea and might connect with her and decide that they would get a vaccine as a result. So I just think just having more folks who are from the communities impacted being able to speak to some of these issues, and then just really also just being able to tailor the messaging to address specific concerns that different communities might have.
Thank you. Do you have any parting thoughts that you want our community to consider or reflect upon or perhaps enact?
Yeah, sure. Yeah, I think, there's this past year, I think, has revealed so much. And I think one thing that people often say is that this is our opportunity to do things differently, to not continue with the status quo. And so it's important, I think, for for the students and other healthcare providers to know that they play a really important role in all of this, and that training, anti-racism trainings, readings, anything that they can do to really enlighten themselves about how we've gotten into this situation, and that they feel empowered to really go out and really think about what are the structural level changes that need to happen and really begin to advocate for that. I think that would be really worthwhile, so that we don't continue getting into situations like this, that we can actually do things differently and ensure that all communities have what they need to thrive.
Thank you so much. It's been an absolute pleasure and privilege to be with you.